This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Good afternoon, everybody. Okay, so I'm going to talk to you about the calling criteria for adults. And of course, we need to get it right. Calling criteria is exquisitely sensitive, then we'll certainly detect all patients, but we'll be far too busy and our ICU registrars will be curled up in a corner in a fetal position. And the system will fall into disrepute. If the calling criteria is too insensitive, then we won't have anything to do, but we'll miss all the patients that we set out to catch. So which variables should we use and what thresholds should trigger the call? Before we get into this, I wanted to just go over some founding principles. So we know this stuff. Serious adverse events are associated with preceding clinical deterioration. And the things we're talking about are unexpected deaths, cardiac arrest, unplanned admission to ICU. And it's the data from the 90s where we started to find out about this stuff. We know that more than 80% of cardiac arrests, more than 50% of hospital deaths, and about 70% of ICU admissions are preceded by deterioration. And similar numbers were found in 2002. Studies by Hillman and Buist. And this paper, or this graph, is taken from a paper where they used 270,000 patient admissions to develop a prediction tool. But the purpose of showing you this graph really is that on the far right is time zero when the event of death, cardiac arrest or ICU transfer happened. And you can see 24 hours before there's a very slow increasing illness score. The patients are deteriorating slowly. There's plenty of time to intervene. So physiologic abnormalities are a marker for clinical deterioration and associated with clinically significant outcomes. The study by Gold, Hill and McNary in 2004, they looked at 433 patients on a single day and followed their mortality for 30 days. Found that 0 abnormal vital signs gives your mortality at 0.7%. 3 or more, your mortality rises to 21.3. And this study here looked at 1.15 million vital signs and their relationship with mortality. They found, similar to Gold, Hill and McNary, that 1 critically abnormal vital sign relates to 0.92% mortality, whereas 3 simultaneous, your mortality goes up to 23.6. And they drilled down into their data and looked at individual vital signs. And when we break their data down into these vital signs versus mortality, the relationships that we know to be intuitive become black and white. So when your systolic blood pressure falls below 90, you can see your mortality rises exponentially. And looking at respiratory rate, we all know that respiratory rate, or tachypnea particularly, is a powerful predictor of critical illness. You look at respiratory rate above 24 and your mortality rises in a linear fashion. The same with heart rate. When your heart rate rises above 120, your mortality tends to go up in a linear fashion. Oxygen saturation is a little harder to predict, or the relationship is a little harder to interpret, but it's clear that SATs below 90 spell trouble. But which physiological markers should we use? So there are plenty to choose from, and these are either currently in use or have recently been used. My favourite's the GIVE trigger. I don't know if you're aware in the room, but the GIVE trigger is the national trigger to pick up organ donation, potential organ donation cases. Stands for GCS less than 5, intubated, ventilated, end-of-life care. So I think as a rapid response team trigger, the horse is probably bolted by then. Is this a problem, all this variability? Well, it makes systems and hospitals very difficult to compare their performance. And I'd like to quote Alex Sarides. I don't know if he's in the audience, but he said this in his paper with Jenny Hill. Geographical variation in abnormal physiology would seem unlikely. I think it's nicely understated, and this applies to the whole world, not just Australia and New Zealand. So why do we have so much variety when we're all humans? Well, it essentially reflects a lack of gold standard for calling criteria. So why choose one variable over another? It should be easily recorded, a component of usual care monitoring, sensitive, specific, shouldn't cost too much. And the timing of the results versus clinical deterioration really refers to laboratory results that some people use. So most bloods are taken in the morning. The deterioration might happen at 3 o'clock in the afternoon. There may not be a relationship between the two. And of course, the bottom one, staff, patient, worried criteria, the subjective criteria, very important. But I'm not going to deal with it here. It's been dealt very nicely by other people at this conference. So that's the subjective versus objective. But let's look at the other things. So the bedside vitals, demographic data such as age, possibly have they been in ICU before, or lab results. Now, we're in ICU and we love numbers. Certainly when we arrive at rapid response team calls, we look for numbers immediately. So why not have them built into the calling criteria? This paper was the one I mentioned before, 270,000 patient admissions. These people developed a prediction tool for the deteriorating patient, and they called it the ECART score. That was their data set, 270,000 patient admissions. And they included demographic variables, vital signs, and a whole lot of lab tests. So the results, they compared the score against the standard calling criteria score, which was used at the time. Most of you will know it. It's a modified early warning score. These numbers up there refer to the receiver operating characteristics curve, or the area underneath the curve. The number 0.5 means that it's a useless test, no better than flipping a coin. So up there you can see values of 0.93 at predicting death are excellent. And the main point of the chart, though, is to demonstrate that it outperformed a vitals-only scoring tool. And what about how we record the physiological abnormalities? Well, manual versus electronic. Some people have alluded to it. Michael DeVita for one, and Phil Sargent before. So there's a few studies out there. Prithvirch and in 2006 did a classroom-style study where they compared as pen and paper versus electronic entry, and found that pen and paper had an error rate of 28%, whereas electronic entry for vital signs had an error rate of 9%. Ronaldo did a before and after controlled trial of automated electronic vital sign monitors and found an increased call for respiratory distress, improved survival, and decreased time to record vitals. And Steve Jones in 2011 did a bedside electronic capture of vital signs with automated clinical alerts, and found improved vital sign entry accuracy, and also got the junior doctors to see the patients a lot more frequently. And finally, this big study from the UK, which came out this year, was the introduction of electronic system with handheld devices. The nurses were prompted to take vitals, and the early warning score was calculated automatically, and they also included lab data. And at the beginning of the study period, they found the crude mortality of the first hospital 7.75%, and at the end of the study period, which is a few years later, crude mortality of 6.42%. The same study was done in the second hospital, about 240 kilometres away from the first hospital, and found a similar result. So regarding electronic devices, I just wanted to put this in here. This is a model or a diagram of a term that I was introduced to recently by Chris Suby, who talked about modular redundancy. Essentially, it's a fancy way of saying backup systems. Computers have them, planes are full of them, and rockets are full of them, but rapid response systems are not. So usually rapid response systems are a single chain of humans, and if one chain fails, the whole system falls down. So perhaps electronic systems can provide modular redundancy in rapid response systems. And this is my image of the future rapid response control system in ICU. And those people are Kickham fellows who can't find a job. So what's going on in New Zealand? Well, first of all, I thought I'd show a map of New Zealand. It's a shame. I don't think Alex is in the room. It's a shame. Okay, so his paper he's talked about, and I won't dwell on it apart from looking at the vital signs. And really what I'm alluding to is some extreme vital signs used in both countries. Okay, so in 14% of hospitals, they used a respiratory rate of 4 or less to trigger a rapid response team call. In 24% of hospitals, respiratory rate of 40 or greater was used. And almost half the hospitals used a systolic blood pressure of 70 or less. And I'm going to go out there and on a limb and say that I think these are extreme and potentially unsafe. There's a map of Australia. So what's going on in Australia? Well, the National Consensus Statement came out in 2010, and which provided guidance so that each hospital could tailor their rapid response system to their own needs. They specified a number of physiological variables to use, and they also suggested that we use thresholds but didn't actually specify what number because of lack of evidence to do so. But if you look at the ANZICS core met investigators, shows the same sort of variability that was seen in New Zealand. And focusing on just one, tachypnea, almost half hospitals use 35 or greater to trigger their rapid response team call. So does it matter? Well, we'll go back to the 1.15 million vital signs and plug in those numbers for calling criteria and show their associated mortality. So if you have a systolic blood pressure of 70, it's associated with a mortality of 10%. If you have a respiratory rate of 40, it's associated with a mortality of 25%. And a heart rate of 140 is associated with a mortality of 10%. Sats below 90 will give you 5%. So it matters because it's directly related to significant clinical outcomes. And what's going on in the UK? Well, they had a lot of variability just like us, but in 2012 they rolled out a national early warning score, so they went for standardisation. And their mantra was, everybody is speaking a common language. So this standardised chart and system was an aggregate system, but you could trigger an extreme score in one box gave you an urgent clinical review. And it's worth noting that those extreme scores are things like SATs of 90, they're the red boxes essentially. So heart rate 40, SATs of 90, respiratory rate of 25, although that's not a red box. So how did they choose those physiological parameters? How did they choose the thresholds for cut-off? Well, the physiological parameters really was a discussion between the implementation group and the National Institute of Clinical Excellence, who did a literature review and looked at the evidence and decided that those physiological variables were the appropriate ones to use. And they are the same ones that the Commission has used as well. Regarding the actual thresholds of the individual vital signs, it's not clear to me how they chose those numbers, but regarding the aggregate scoring and where to choose the certain clinical response, they certainly use sensitivity. They determined sensitivity by looking at the frequency of clinical reviews at different scores, and they tested the specificity against other early warning scores for predicting mortality. They used this large database and came up with this. That's just a generic receiver operating characteristic curve, but the news score essentially was 0.89, which corresponds with that yellow line and means that it's very good at predicting mortality within 24 hours of assessment. So it performed well. So it's worth talking about the benefits of standardising in Australia and New Zealand. Essentially, the benefits would be that we reduce variability between health facilities, and which would enable us to decrease error due to unfamiliarity, which is most appropriate for workers who go between hospitals. And training and education will be easier to roll out and could start at a medical student level. Data collection, obviously easier. not only for research but for refinement of systems as we go forward. And more relevant to this talk, it will provide impetus for achieving consensus with calling criteria across the two countries. Safe minimum standards could be developed and optimal sensitivity and specificity levels determined. So how are we moving forward? Well, as mentioned, there is a statement which will be coming out probably next year, which has combined ANZICS and KICM on the intensive care role in rapid response systems, and part of the process will be drilling down into the data but also achieving consensus on calling criteria amongst other things. The database, the binational database, will be discussed tomorrow. There seems to be a bit of momentum for that. And I'm interested to see what further discussions happen about electronic monitoring, which might include laboratory and demographic data in addition to vitals. So in summary, we can predict and prevent adverse outcomes for patients. Some calling criteria thresholds are arguably unsafe. There's lots of variability in the system at the moment, and perhaps standardisation is the way to go. And my children say thank you because they'll grow up to be patients one day too.